Good day, dear students. As you see, today we will tell about hormones. And in mammals, there is a division of metabolic labor among the specialized tissue and organs, and coordination of the body. Diverse metabolic activities is achieved by hormonal and neuronal signaling. Individual cells in one tissue sense a change in the organism circumstances and responds by the secreting of extracellular chemical messenger. Endocrine cells secretes hormones. Neuron secretes neurotransmitters. In each case, the extracellular messenger passes to another cell where it binds to a specific receptors molecules and triggers the change in the activity of the second cell. Some of the chemical messenger are common for both systems. For example, epinephrine and norepinephrine. They serve as neurotransmitters in the certain synapses of the brain and smooth muscles, and also as a hormones regulating fuel metabolism in the liver and in the muscles. If we tell about the variant of the action of hormones, we can classify them in the next, you see, different types. In chemical signaling, the cell can target itself. It's endocrine and intracrane signaling. In intracrane signals is generated by a chemical acting within the signaling cells itself and without the leaving of the cell. So see here that this chemical signaling is produced inside of the cell and bind with receptors inside of the same cell, changing the metabolism of this cell. In autocrine mechanism of action, signals here they are produced inside of the cell, after that leave from the cell and interact with receptors on the plasma membrane of the same cell. In paracrine mechanism of action is defined as a chemical bond between the neighboring cell, as you can see here. It's a local mechanism of action and a chemical released by a specialized group of the cell into the bloodstream and acting on a distant target tissue determines as a classical endocrine or neuroendocrine mechanism of action, signaling mechanism. And but this classification, the same is not absolutely classic, because some of hormones, they have mixture of this effect. For example, insulin. You know about the classical endocrine function of insulin, but insulin, which is produced in the beta cell of the pancreas, can regulate production of glucagon in the alpha cell with the paracrine mechanism of action. But mainly today we'll tell about clear endocrine hormones. That's why we will give definition of hormones, that hormones, the chemical substances synthesized in a small amount by the endocrine tissues and carried into the blood to another tissue, where it is act as a messenger to regulate the function of the target tissue or organs. The word hormone is derived from the Greek verb hormone, meaning the stop up or excite. In the endocrine system, hormones are secreted by the producing cell into the bloodstream, which carries them throughout the body to target tissue, maybe more than a meter away from the secreting cell. And the final link in the system is that hormones interact with special receptors on or in the target cells, triggering responses. And only if cell has this receptor, it is a target cell. If cell has no receptor, it is not target cell. And these cells can interact with hormones and can't answer on hormones action. Release of this hormone is regulated by other hormones, by nerve signals, and by signals from the target organs, indicates a decreased needing for the stimulating hormones. If we tell about the functions of hormones, of course, on the first place is a homeostasis function. Together with this, we have a number of hormones that took part in regulation of the reproduction functions of our body. Some of hormones influence on the growth and development of the cell, tissue, and organism whole. Some of hormones, they maintain the internal environment. Production, utilization, and storage of energy depend from the regulatory function of some of hormones, number of hormones. You see that as a minimum, a hormonally regulated system must include a secretory gland, a receptor for the hormone on or within target cell, and some feedback mechanism, complex of feedback loops that regulate the secretion of hormone in response to the function being regulated. Hormones function in the complex hierarchy. Hormone act in a hierarchy function because at the top of this hierarchy is a hypothalamus hormones. Later we will tell about hormones which are produced in the hypothalamus. The next in this hierarchy system is pituitary gland. And after the next level already, there are a number of peripheral endocrine glands like adrenal gland, pancreas, ovaries, testes, thyroid glands, and so on. There are many different classifications of hormones. We can classify them according to the mechanism of action, according to their solubility. But today we'll tell about two populist classification of hormones. One of classification of hormones according to the anatomical source of their synthesis, according to the places of their synthesis in a hierarchy of their function. And as you see, the top of the system is hypothalamus. All hypothalamic hormones. Next level, they are pituitary hormones. And after that already, next level, they are hormones of peripheral endocrine glands. One more classification of hormones, according to their chemical structure. And here we can classify them in four main chemically distinct classes. Peptides, where we include not only short peptide hormones, but and long proteins. Peptide hormones, they can have from 3 to over 200 amino acid residues. Includes of all hormones of the hypothalamus and pituitary and pancreatic hormones. Some of these proteins, they are complex proteins, mainly glycoproteins, which contain smaller polysaccharides chain, usually branched chain, like LH, FSH, luteinizing hormones or follicular stimulating hormones. Some of the peptides, they are simple proteins, they consist only from amino acids, like prolactin, insulin. One more class of hormone, they are amine hormones, low molecular weight compounds derived from the amino acid tyrosine. Include water-soluble epinephrine and norepinephrine of the adrenal medulla and less water-soluble thyroid hormones. The next class is steroid hormones. Steroid hormones are fat-soluble, include the adrenocortical hormones and the male and female sex hormones. They move throughout the bloodstream bound to a specific area protein because, as you tell, they are insoluble in water. And all of steroid hormones, they are derivative of cholesterol. And at last, icosanoids are derivatives of the 20-carbon polyunsaturated fatty acid arachidonate. All three subclasses of icosanoids, prostaglandins, leukotrienes, and thromboxanes, they are unstable and insoluble in water. These signaling molecules generally do not move far from the tissue that produces them, and they act primarily on the cell very near their point of release. They are local hormones, and as you understand already, they have paracrine mechanism of action. Here you can see the picture of all these classes of hormones. Proteins, which consist from amino acids. Example of steroid hormones, and you see the base of all steroid hormones. It's a derivative of cholesterol, here cholesterol and different steroid hormones. Amino hormones, which are derivatives of amino acid tyrosine. And here you can see example of icosanoids, prostaglandin. It's a derivative of 20 polyunsaturated fatty acid, arachidonic fatty acids. If we tell about the functions of hormones, we already discussed the functions. Now let's tell about the difference in the properties of hormones. All peptide or protein hormones, they are hydrophilic. They are big, large molecules. They can't fit through the membrane. They use second messenger mechanism of action. The most of our hormones, they are peptide hormones. And the famous example of them, of course, insulin. If we tell about the properties of steroid hormones, they are smaller than peptide, of course. They are hydrophobic. For their transportation in the blood, necessary special transport protein or albumin is minimum. They have cytoplasmic or nuclear receptors, and they interact with a special site of DNA and change the transcription. They took part in regulation of transcription, and such way they took part in regulation of protein synthesis. For example, estradiol. Let's start to tell about these hormones in detail, and we start to tell about the peptide or proteins hormones. And we will tell about them according to the hierarchy of their synthesis and function. And you know already that on the first place at the top of here is a hypothalamic hormones. Hypothalamus is a specialized center in the brain near a pituitary gland. And while it's very small, the hypothalamus play a critical, important role in many important functions, including maintaining daily physiological cycles, controlling appetite, managing of sexual behavior, regulating emotional responses, regulating body temperature, and as you already know, releasing hormones. And due to this endocrine function, hypothalamus took part in the coordination of all endocrine system of our organism. It receives neuronal input from the diverse region of the brain and feedback signals from the hormones circulating in the blood. These signals are integrated in the hypothalamus which responds by releasing of appropriate hormones to the next tissue in the cascade, the pituitary. The hormone secreted by the hypothalamus is relatively short peptide, produced in a very small quantity. Some hypothalamic regulatory hormones, they stimulate anterior pituitary to secrete hormones in the pituitary. Some of them, they inhibit the production of hormone in the pituitary. The hypothalamic hormones pass directly to the nearby pituitary gland throughout a special blood vessels and neurons that connect to this gland. And the pituitary gland, of course, is the main, the master endocrine gland in the body. Such price justified in the sense that anterior and posterior pituitary secrete a battery of hormones that collectively influence all cells and affect virtually all physiological processes. But pituitary, of course, pituitary gland may be a king, but a power behind the throne is clearly hypothalamus. That's why it's so important, because hypothalamic hormones control pituitary hormone production. Hypothalamus produce two types of hormones. And these hormones are carried directly to anterior pituitary gland via the hypothalamic hypophyseal portal vein. Specific hypothalamic hormones binds to a receptor on specific anterior pituitary cells, modulating the release of the hormone they produce. And we can classify all hypothalamic hormones on two groups. Liberins or releasing hormones, which stimulate the release of the corresponding trophic hormones from the anterior pituitary. And here you can see corticotropin releasing hormones, one more name of each is corticoliberins, which increase production of corticotropin in the anterior pituitary. Thyrotropin releasing hormone that stimulate the release of thyrotropin or thyroid stimulating hormone from the front of pituitary gland. One interesting aspect about thyroid releasing hormones or thyroleberins. This hormone consists only from 3 amino acids. It's a tripeptide. Its basic sequence is glutamic acid, histidine, and proline. You see, the shortest peptide in our body. Next hormone of hypothalamus is gonadotropin releasing factors or gonadoliberins. Next is growth hormone releasing factor or somatoliberins. And at last, prolactoliberin or prolactin releasing factors. And we know only two statins or inhibiting hormones, somatostatin and prolactostatin or prolactin inhibiting factors. Pay attention on this gonadotropin releasing hormone. It's a decapeptide. It consists from 10 amino acids. And you know that all of our proteins, they consist only from alpha amino acid. We have a special medicine, diafereline or Zoladex, which is administered for the treatment of prostate cancer, myoma, endometriosis, hyperplastic processes of endometrium, and many other diseases. This hormone also we use for the treatment of infertility. It is the same decapeptide, but it's a synthetic analog of gonadotropin releasing hormone. And it is different from this nature gonadotropin only because it has one D amino acid instead L amino acids. In such way, this synthetic medicine, diafereline, can bind to receptor of gonadotropin releasing factors in anterior pituitary and block it and prevent production of gonadotropins. You see, very interesting mechanism of action. And this mechanism of action, like a competitive inhibition, it binds with the same receptors and prevent action of hormones. And very widely we use this drug in the medicine for the treatment of the number of different diseases. Now let's tell about the pituitary hormone. Pituitary gland consists from three lobes: anterior pituitary, intermediate lobe, and posterior pituitary, and each of them produce their own protein, their own hormones. The anterior pituitary, under control of hypothalamic hormones, secreted a number of trophic hormones that regulate the growth and the function of other endocrine glands or influence metabolic reactions in other target tissue. You see here growth hormone, TSH, thyroid stimulating hormones, ACTH, adrenocortic hormones, prolactin, and gonadotropins. In intermediate lobe, melanocyte stimulating hormone is produced, and in posterior pituitary, antidiuretic hormones, vasopressin, and oxytocin. Let's tell now about each of these hormones especially. But before this, I want to show you that some of hormones of anterior pituitary, they regulate production of hormones in other peripheral glands, like ACTH took part in regulation of hormone production in adrenal cortex. Gonadotropins, like LH, can regulate production of the gonads, ovaries, and testes. Thyroid hormones regulate production of hormones in thyroid glands, but some of them, like prolactin and growth hormone, the same has direct action. They can regulate metabolism already directly in their target organs. Growth hormone. Growth hormone, also called somatotropin. It consists of 191 amino acids. And it is synthesized and secreted by the cell called somatotrophs in the anterior pituitary. If we tell about regulation of the growth hormone secretion, production of the growth hormone is modulated by many factors, including stress, exercise, nutrition, sleep. However, its primary controller are two hypothalamic hormones and one hormone from the stomach. Growth hormone releasing factors is a hypothalamic peptide that stimulate both in synthesis and secretion of growth hormone in the pituitary. Somatostatin upside down lead to the block of growth hormone synthesis. Somatostatin inhibits both synthesis and excretion of this hormone. The other stimulatory factors that can increase production of this growth hormone is, for example, a low blood glucose concentration. The same is an activator of the growth hormone secretion. Now pay attention on this. Ghrelin. Ghrelin is a peptide hormone secreted from the stomach. Ghrelin binds to receptor on the somatotrophs and potently stimulate secretion of the growth hormone. Growth hormone secretion is also part of the negative feedback loop, you see, involving an insulin-like growth factors 1. High blood level of the insulin-like growth factors 1 leads to decreased secretion of the growth hormone, not only by directly suppresses of the somatotrophs, but by stimulating release of somatostatins from the hypothalamus. Growth hormone also feeds back to inhibit growth hormone releasing factor secretion and probably has direct autocrine inhibitory effect on secretion from the somatotroph. Integration of all of the factors that affect on growth hormone synthesis and secretion lead to pulsative pattern of release. More than half of the total daily amount is released during early sleep, and the highest concentration soon after sleeping. That's why it's absolutely correct when we tell that we are growth during sleeping. It's really so, because during our sleeping, the concentration of the growth hormone is the highest. If we tell about the activity of growth hormone or somatotropin, it has two types of effect, direct and indirect. Direct effect are the result of the growth hormone binding its receptor on target cell. Growth hormone receptors are found in the plasma membrane of the liver cells, adipose tissue, testes, corpus luteum, skeletal muscles, cartilage, brain, lung, pancreas, intestines, heart, kidneys, and lymphocytes. Growth hormone, for example, stimulates the breakdown of triacylglyceride and suppresses ability to take up and accumulate circulating lipids in the fat cells, in adipocytes. But growth hormone has indirect effect the same. Indirect effects are mediated primarily by the insulin-like growth factors 1, IGF-1, or somatomedins, which is a hormone that is secreted in the liver, mainly in the liver, but in other tissues in response to growth hormone. The majority of the growth promoting effect of the growth hormone is actually due to these insulin-like growth factors 1 acting on this target cell. These insulin-like growth factors act in different ways: endocrine, paracrine, and autocrine. If we tell about the effect of growth hormone on the growth of our body, insulin-like growth factors 1 stimulates proliferation of chondrocytes, cartilage cell, resulting in bone growth. Growth hormone does seem to have a direct effect on the bone growth in stimulating differentiation of the chondrocytes. IGF-1 also appears to be the key player in the muscle growth. It stimulates both and differentiation and proliferation of the myoblasts. It also stimulates amino acid uptake and protein synthesis in the muscles and in other tissue. But the effect of somatotropin on the body growth is closely related to its metabolic effects. Growth hormones has important effect on protein, lipid, and carbohydrate metabolism. In some cases, a direct effect of growth hormone has been clearly demonstrated in other. Insulin-like growth factors 1 is thought to be critical mediator. In some cases, it's appearing in both effect and direct and indirect effect on the metabolism of our body. If we tell about the protein metabolism, in general, growth hormones stimulate protein anabolism in many tissues. Under the influence of growth hormone, the transport of amino acid into the cell and protein synthesis in the bones, cartilage, muscles, liver, and other internal organs is increased. The total amount of RNA, DNA, and the total number of cells increase. If we tell about regulation of fat metabolism, growth hormone enhances the utilization of fat by stimulating triacylglycerol breakdown and beta oxidation of fatty acids in the adipocytes and other organs, in the liver the same. Carbohydrate metabolism, the same, is regulated by growth hormone. But growth hormone is only one of the battery of hormones that is served in the maintenance of the blood glucose within the normal range. Growth hormone is often said to have anti-insulin activity because it suppresses the abilities of insulin to stimulate uptake of glucose in the peripheral tissue and enhance glucose synthesis, gluconeogenesis in the liver. It's the same took part in stimulating of breakdown of the glycogen and prevent glycogenesis, synthesis of the glycogen. State of the both growth hormone deficiency and excess provide very visible testaments to the role of this hormone in normal physiology. Disorders can be lesions in either the hypothalamus, abnormal regulation, or pituitary, abnormal production, or in target cells, no reactions, and something happened in the receptors for the growth hormone. Clinically, deficiency in the growth hormone or receptors defect are as a growth retardation or dwarfism. Here you can see the picture. You see that proportion of the body here is absolutely normal. Mentality is absolutely normal. Only we can see the growth retardation. The manifestation of the growth hormone deficiency depends upon the age of onset of the disorders and can be result either heritable or acquired disease. The effect of excessive secretion of the growth hormone is also very dependent on the age of onset, and it's seen as two distinctive disorders. Gigantism. Gigantism is the result of excessive growth hormone secretion that begins in the young children or adolescents. In other words, the hypersecretion begins before to closure of the growth centers in the long bones. Gigantism with the normal body proportions and normal sexual development, absolutely normal mentality, but abnormal excess height and weight. This disorder usually resulting from the tumor of somatotrophs. Gigantism is usually treated with radiation, but gland surgery may also be used. One more variant of the excess of growth hormone is acromegaly. Acromegaly results from the excessive secretion of somatotrophs in adult after the growth center have closed. The bone grows in bulk and width. Clinically, an overgrowth of the bone and connective leads to change in appearance that might be described as having coarse features. See here, absolutely normal in the young, and what happened with this patient, this woman, during the age when suddenly after some yes, usually in adult after 16 years old, happened the increasing of the growth hormone production. Here we can see increasing of the bones only on the face, jaw, arms, and legs. They get larger because epiphysis of these bones don't close this. The excessive growth hormone and insulin-like growth factors also lead to metabolic derangement, including glucose intolerance. The treatment here, we treated by the X-ray to shrink the pituitary, or part of the pituitary gland is removed. Now let's tell about thyroid stimulating hormone or thyrotropin. Thyroid stimulating hormone, also known as a thyrotropin, is secreted from the cell in the anterior pituitary, called Thyrotrophs. Finds its receptors on epithelial cells in the thyroid glands and stimulate that glands to synthesize and release thyroid hormones, thyroxine and triiodothyronine. Thyroid stimulating hormones, TSH, is a glycoprotein hormone composed of two subunits, alpha and beta, and these subunits non-covalently bound to one another. It is interesting, but the alpha subunit of TSH is also present in two other pituitary glycoproteins hormones, LH and FSH, and in the placental hormones chorionic gonadotropin. Each of these hormones has also a unique beta subunits. You see, alpha subunits are common for them, but they have the unique beta subunits. And these beta subunits provide receptor specificity and specificity of their action. TSH activates all stages of the synthesis of T3 and T4 in thyroid glands. It stimulates capture of iodine by follicular cells in the thyroid gland. It stimulates iodinization of thyroglobulin in the lumen of follicle and protein precursor. This is thyroglobulin is a protein precursor of thyroid hormones. TSH stimulates conjugation of iodinated tyrosine residues. This results in the formation of thyroxine T4 and triiodothyronine T3, which remain attached to the thyroglobulin protein. After that, it stimulates the proteolysis of iodinated thyroglobulin with the formation of free already T3 and T4. And at last, it stimulates the secretion of these hormones, thyroxine and triiodothyronine, into the bloodstream. All of these steps of T3 and T4 synthesis in the thyroid gland is under control effect of the TSH. But TSH the same is regulated with different controllers. The most important controller of TSH secretion is, of course, thyroid releasing hormones of the hypothalamus. Thyroid releasing hormone, as I tell already, is secreted in the hypothalamus, and after that it goes to the anterior pituitary into the hypothalamic hypophyseal portal blood and finds its receptors on thyrotrophs in the anterior pituitary and stimulate secretion of TSH. And of course, traditionally, we have a number of feedback regulation. Deficiency of TSH or maybe mutant TSH receptors. Some people inherit mutant TSH receptors, resulting in hypothyroidism. Some people develop antibodies against their own TSH receptors. When these bind the receptors, they fool the cell into making more T4, causing hyperthyroidism. the condition called thyrotoxicosis or Graves' disease. The deficiency of TSH causes hypothyroidism and, of course, decreases the production of T3 and T4, an inadequate level of these hormones. Next hormones of anterior pituitary is ACTH, Adrenocorticotropic hormone. It is a single chain polypeptide consisting of 39 amino acids, and its name implies that this hormone stimulates adrenal cortex. More specifically, it stimulates secretion of glucocorticoids, first of all cortisol, and has a little control over secretion of aldosterone, the other major steroid hormones from the adrenal cortex. It's stimulated by the ACTH influences on the conversion of the cholesterol to pregnenolone. Another name of ACTH is corticotropin. ACTH is secreted from the anterior pituitary in response to corticotropin releasing hormone from the hypothalamus. Corticotropin releasing hormone is secreted in response to many types of stress, which makes sense in view of the stress management function of the glucocorticoids. Corticotropin releasing hormone itself is inhibited by glucocorticoids, making it part of the classical negative feedback loop. Within the pituitary gland, ACTH is produced in the process that also generates several other hormones. A large precursor protein named propionmelanocortin is synthesized and proteolytically chopped into several fragments. The main hormones other than ACTH that are produced in this process is lipotropin, originally described as having quick lipotrophic effect. Its major importance is the precursor of beta endorphin. Beta endorphin and methencephalin, they are opioid peptides with the pain, elevation, and euphoric effects. And pay attention that melanocyte stimulating hormone, the same, is produced from this precursor. It can be present in different forms. The populist of them, alpha MSH, melanocyte stimulating hormone, which consists from 13 amino acids, and beta MSH, which consists from 21 amino acids. Stimulate the product, all variant of MSH, they stimulate production of the pigment melanin by the melanocytes in the skin. And I hope that you remember that melanin, the same, is produced from amino acids tyrosine. Prolactin. Prolactin is a protein of 199 amino acids. Prolactin, acting with other hormones, starts the growth of the mammary gland. For example, estrogens provide a well-studied positive control over prolactin synthesis and secretion. The increasing blood concentration of estrogen during late pregnancy appear responsible for the elevated level of prolactin that are necessary to prepare the mammary gland for lactation at the end of gestation. After childbirth, it helps to start and maintain the making of the breast milk. This occurs in responsible to suckling by the infant, stimulation of the nipples and mammary gland, as occurs during the nursing leads to prolactin release. This effect appears to be due to a spinal reflex arc that causes release of prolactin-stimulating hormones from the hypothalamus. When suckling stops, prolactin slow and breast stop making produce. Again, you can see that prolactin induces loboalveolar growth of the mammary gland. Prolactin stimulates lactogenesis and milk production. Milk production. After giving birth, prolactin along with cortisol and insulin act together to stimulate transcription of genes that encodes milk and proteins. See? After stimulation, in response to cycling, signal goes to hypothalamus with in such way activate production of prolactoliberins, which in turn increase production of prolactin in anterior pituitary, which act lead to the growth, proliferation and increase of the breast and stimulate production of milk. This important function of prolactin determined the name of this hormone, prolactin. But prolactin is multifunctional hormones. Prolactin induces lobular-alveolar growth, not only the growth of the mammary gland. It maintains the corpus luteum, and deficiency of this function can lead to defect in the ovulation, fertilization, pre-implantation development, and implantation the same. Prolactin receptors are present in the cell of many tissues, in the liver, kidney, adrenal gland, testes, ovaries, uterus, and other tissues. Prolactin activates the synthesis of phospholipids and triacylglycerol. Prolactin took part in regulation of sex hormone synthesis. In men, prolactin increases the sensitivity of the Leydig cells to luteinizing hormones and thus maintains the required level of testosterone synthesis. Only at a normal level of this hormone are sperm able to successively develop and work correctly. Prolactin effects on body weight participate in the development of secondary sexual characteristics and in the formation of sexual desire. In the kidney, prolactin reduces the excretion of the water, effect on the reabsorption of sodium and potassium ions. Prolactin also enhances humoral and cellular immunity. You see how many functions. That's why excessive secretion of prolactin, hyperprolactinemia, has different symptoms. And it is a relatively common disorder in the humans. Hyperprolactinemia has numerous causes, including the prolactin-secreting tumors and therapy with the certain drugs. Common manifestation of hyperprolactinemia in the women include amenorrhea, the lack of menstrual cycle, and as a result, disorder of reproductive function, and galactorrhea, excessive and spontaneously secretion of the milk. Men with hyperprolactinemia typically show hypogonadism with the decreased sex drive, decreased sperm production, and impotence. Such men also often show breast enlargement, gynecomastia, but very rare produce milk. Gonadotropins. Gonadotropins includes two hormones, luteinizing and follicle-stimulating hormones. Luteinizing hormones, LH, and follicular-stimulating hormone, FSH. I think that you already understand that they are called gonadotropins because they stimulate the gonads in male the testes and in female the ovaries. These two hormones are secreted from the cell in the anterior pituitary called Gonadotrophs. They are not necessary for life, but they are essential for reproduction. LH and FSH, they are large glycoproteins, and we already tell about this, that they are composed of alpha and beta subunits. The alpha subunits is identical in all these hormones, and the beta subunits is unique and endows each hormone with the ability to bind its own receptor and to show its own effect. Control on gonadotropin secretion is typical. The principal regulation of LH and FSH secretion is gonadotropin releasing hormone, which is produced in the hypothalamus. Gonadotropin releasing hormone stimulates secretion of LH, which in turn stimulate gonadal secretion of the sex steroids testosterone, estrogen, and progesterone. In classical negative feedback loop, sex steroid inhibits secretion of the gonadotropin releasing hormones and also appear to have direct negative effect on gonadotrophs of the anterior pituitary. If we tell about the effect, physiological effect of this hormone, luteinizing hormones in both sexes. LH stimulates secretion of the sex steroids from the gonads. In female, ovulation of the mature follicles in the ovary is induced by the large dose of LH, secretion known as a pre-ovulatory LH surge. Residual cells within the ovulation follicles proliferate to form corpora lutea, which secrete the steroid hormones progesterone and estradiol. Progesterone is necessary for the maintenance of the pregnancy, and it's the most in the most mammals, and in our organism the same. LH is required for the continued development and function of the corpora lutea. T cells in the ovary respond to LH stimulation by the secretion of the testosterone, which is converted into the estrogen by adjacent granulosa cell. In the testes, in the male, LH binds to its receptor on the Leydig cells and stimulates synthesis and secretion of testosterone. Follicle stimulating hormones. FSH stimulates the maturation of the ovarian follicles. Administration of FSH to human and animals induces superovulation or development of the more than usual number of mature follicles and hence an increased number of mature gametes. FSH is also critical for the sperm production. It supports the function of Sertoli cells, which in turn support many aspects of the sperm cell maturation. And if we tell about the imbalance of gonadotropin synthesis, insufficient production of testosterone by a boy's testes resulting in undeveloped male secondary sexual characteristics, failure of production of the normal number of the sperm. In females, cessation the reproductive cycle in common observed. Elevated blood level of gonadotropin usually reflect the lack of steroid negative feedback. Removal of gonads from the egg of the males and females is the common done animals lead to persistent elevation of LH and FSH. In human, excessive secretion of these hormones can be result of the gonadal failure or pituitary tumors. In general, elevated level of gonadotropins have no biological effect. Effect, we will see negative effect only when we tell about the lack of this hormone. That's all about hormones of the anterior pituitary. Now let's tell about the posterior pituitary hormones. Posterior pituitary contains two active hormones, oxytocin and ADH, antidiuretic hormone. The posterior pituitary contains the axonal ending of many neurons from the originate of the hypothalamus. And in these neurons, two short peptide hormones, these oxytocin and vasopressin, are formed from the longer precursor peptide. It happened in the hypothalamus. Only after that, these peptide hormones move down hypothalamic axons to the nerve ending in the pituitary, where they are stored in the secretory granules. And they are both, you see, they are nanopeptide. You see, here that's why we can confuse. These hormones are pituitary hormones or hypothalamic hormones. But you see that they are released into the blood from the pituitary. That's why we will think that they are posterior pituitary hormones. Both of them, they are nanopeptide. They consist from 9 amino acids. And they differ from each other only in 2 amino acids. Pay attention. They are differ only in 2 amino acids. Here leucine, here arginine. Here isoleucine, here phenylalanine. All other amino acids in them, they are absolutely the same. Antidiuretic hormone or vasopressin. Very important hormone, of course, because you know that approximately 60% of the body weight is water. And despite wide variation of the amount of water taken in each day, body water constant remained very stable. Such precise control of the body water and solute concentrations is a function of the several hormones acting on the both of the kidneys and vascular system. And we will tell about some of them, but there is no doubt that antidiuretic hormone is a key player in these processes. Antidiuretic hormone is given off by the hypothalamus and stored in the pituitary gland. ADH is released when the blood volume falls, when a large amount of salt shown up in the blood, or when pain, stress, or certain drugs are present. Nicotine and a large doses of certain drugs causes ADH to be released. Vice versa, alcohol slows the making of hormone. The single most important effect of antidiuretic hormone is to conserve the body water by reducing the output of urine. Antidiuretic hormone binds to the receptor in the distal or collecting tubules of the kidney and promotes reabsorption of water back into the blood, into the bloodstream, into the circulation. In the absence of the antidiuretic hormone, the kidney tubules are virtually impermeable to water and it flows out as urine. Antidiuretic hormones causes also contractions of arterioles, which lead to increases arterial pressure. That's why ADH has one more name, vasopressin. The hormone increases blood pressure with the increases reabsorption of water in the kidney after signals from baro and osmoreceptors. The most important variable regulation antidiuretic hormone secretion is plasma osmolarity, or the concentration of solutes in the blood. Osmolarity is sensed in the hypothalamus by neurons known as the osmoreceptors. And those neurons in turn stimulate secretion from the neurons that produce antidiuretic hormone. When plasma osmolarity is below a certain threshold, the osmoreceptors are not active and antidiuretic hormone secretion is suppressed. When osmolarity increases above the threshold, the osmoreceptors recognize this and stimulate the neurons that secrete antidiuretic hormone. Secretion of ADH is also stimulated by decreases in the blood pressure and volume, conditions set by the stretch receptor of the heart and large arterioles, baroreceptors. Changes in the blood pressure and volume are not nearly as sensitive as the stimulation of the osmoreceptors, but are nonetheless potent in the severe conditions. For example, loss of 15 or 20 of the blood volume by hemorrhage results in the massive secretion of antidiuretic hormone. The most common disease of men related to antidiuretic hormone is diabetes insipidus. This condition can arise from either of two situations: hypothalamic central diabetes insipidus resulting from the deficiency in the secretion of ADH from the posterior pituitary. Causes of this disease include head trauma or infection or tumors involving the hypothalamus. And second variant is nephrogenic diabetes insipidus, occurring when the kidney is unstable to respond to ADH. Most commonly, this results from the same type of renal disease, but mutation in the ADH receptor gene or in the some gene encoding aquaporin 2 have also been demonstrated in affected human. The major sign in either type of diabetes insipidus is excessive urine production. Some human patients produce as much as, pay attention, you see, terrible, 16 liters of urine per day. The more common symptoms are, of course, this is a strong thirst and, of course, polydipsia. They drink a lot. Urination, polyuria, nocturia, dry skin, dehydration, constipation. The next hormone which is produced from posterior pituitary is oxytocin. It's the same peptide, consists of the 9 amino acid. And oxytocin acts on the smooth muscles of the uterus and mammary gland, causes uterine contraction during the labor, and promoting milk release during lactation. The most important stimulator for the release of the hypothalamic oxytocin is initiated by the physical stimulating of the nipples. The act on the nursing or cycling is related within the few milliseconds to the brain via a spinal reflex arc. This signal acts on oxytocin secreting neurons, leading to release oxytocin. Number of factors can inhibit oxytocin release, among them acute stress, For example, oxytocin neurons are repressed by the catecholamines, which are released from the adrenal gland in response to many types of stress, including fright. Pay attention that milk is produced under the action of prolactin, but milk is excreted due to the contraction of the smooth muscles of the milk duct. And here it influences of oxytocin. Oxytocin is released during the labor when in fetus stimulate the cervix and vagina, and it enhances contraction of the uterus smooth muscles to facilitate participation of the birth. Both sexes secrete oxytocin that above its role in males. Males synthesize oxytocin in the same regions of the hypothalamus as in the females, and also within the testes and perhaps other reproductive tissue. Pulses of oxytocin can be detected during ejaculation. Current evidence suggested that oxytocin is involved in facilitating sperm transport within the male reproductive system and perhaps also in the female due to the presence in the seminal fluid. It may also have effect on the some aspect in the male sexual behavior. In the brain, oxytocin acts as a chemical messenger and has the important role in the many human behaviors, including sexual arousal, recognition, trust, romantic attachment, and mother-infant bonding. As a result, oxytocin has been called as a love hormone or cuddle hormone. And studies has proven the connection of oxytocin in the human relationship, increasing confidence and reducing fear. This suggested that oxytocin may influence areas of the brain responsible for the behavior, fear, and anxiety. That's all about the central hormones, hormones of the pituitary and hypophysis. And now let's tell about the peptide hormones which are produced in the peripheral endocrine glands. And we start from the hormones of the pancreas. You know that pancreas has two major biochemical functions. Endocrine cells provide digestive enzymes or secretion into the intestine, and endocrine cells produce and secrete peptide hormone that regulate fuel metabolism throughout the body. The peptide hormones, insulin, glucagon, and somatostatin, all of them, they are produced by the cluster of specialized cells called the islets of Langerhans. Each islet cell type produces a single hormone. Alpha cell produce glucagon, beta cells insulin, and delta cell somatostatin. Insulin. Insulin is a small protein, active insulin, with two polypeptide chain, A chain, which consists from 21 amino acids, and B chain, which consists from the 13 amino acids. 30 amino acids. Both this chain joins by the two disulfide bonds. It is synthesized in the pancreatic beta cells as inactive single-chain precursor, pre-proinsulin, with amino terminal signaling sequence which contains 24 amino acids that direct its passage into secretory vesicles. Proteolytic removal of the signal sequence, you see here, and formation of the disulfide bond produce proinsulin, which is stored in the secretory granules in the beta cell. When elevated blood glucose triggers insulin secretion, proinsulin is converted into active insulin by specific peptidases, which cleave two peptide bonds to form the major insulin molecule, an S-peptide. S-peptide contains 31 amino acids. You see, we break down two peptide bond here and here, cleave this S-peptide and join together alpha and alpha A and B chains of insulin. When glucose enters the bloodstream from the intestine after carbohydrates-rich meals, the resulting increase in the blood glucose causes increased secretion of insulin and decreased secretion of glucagon. And insulin stimulates glucose uptake by the tissue, where the glucose is converted to glucose 6-phosphate. Insulin also activates glycogen synthesis and inactivates glycogen phosphorylase, so that much of the glucose 6-phosphate is channeling into glycogen. As a consequence of the accelerated uptake of glucose from the blood glucose concentration falls to the normal level, slowing the rate of insulin release from the pancreas. Thus, there is a closely adjusted feedback relationship between the rate of insulin secretion and the blood glucose concentration. The effect of this regulation is to hold the blood glucose concentration nearly constant in the face of the large fluctuation in the dietary intake of glucose. And the main top function of insulin is, of course, decreases the level of glucose in the blood. From the battery of the hormones that influence on the glucose concentration in the blood, only insulin decreases the glucose level in the blood. Only insulin. All other hormones in the influence on the carbohydrate metabolism, they increase the level of glucose in the blood. Insulin also stimulates the storage of excess glucose as fat. It activates both the oxidation of glucose 6-phosphate to pyruvate via the glycolysis and the oxidation of pyruvate to acetyl-CoA. Acetyl-CoA, not oxidized further for energy production, is used for the, some of them of course is used for the energy production, but excess of acetyl coenzyme is used for fatty acid synthesis in the liver, and these fatty acids are exported to the triacylglycerol of plasma lipoproteins. You know that very low density lipoproteins are produced in the liver and after that go to the adipose tissue. Insulin stimulates triacylglycerol synthesis in adipocytes using fatty acid released from the very low density lipoproteins triacylglycerol. These fatty acids are ultimately derived from the excess glucose taken from the blood by the liver. So insulin stimulates production of the fat from the excess of glucose in the absorption time. In summary, the effect of insulin is to favor the conversion of excess blood glucose into two storage forms: glycogen in the liver and muscles and triacylglycerol in adipose tissue. On this slide, you can see the table where we can see the effect of insulin on different way of our metabolism. And here you can see the target enzymes in this way. You see? And you see that insulin stimulate activity of these enzymes and decrease activity of glucose production from the glycogen. And of course, insulin decrease activity of gluconeogenesis. That's why when we tell about the absence of insulin, problem with its production in the pancreas, it's a diabetes mellitus of the first type, or intolerance of tissue for insulin, resistance of the tissue, it's a diabetes mellitus of the second type, or in both of this variant, the symptoms are the same. Polyuria, polydipsia, polyphagia, and ketoacidosis. Why a pair of these symptoms? Let's see. Deficiency of insulin or resistance of insulin, so absence of insulin action, lead to increase of gluconeogenesis, because we know that insulin is an inhibitor of these processes. In the absence of insulin, we decrease utilization of glucose from the blood into the cell, transport of glucose from blood into the cell. Without insulin happens the increasing of glycogenolysis, breakdown of glycogen in the liver and muscles. All of these reasons lead to hyperglycemia, increasing of the level of glucose in the blood. It leads to increasing of osmolarity of the blood. But if the level of glucose in the blood becomes higher than threshold, it leads to the releasing of glucose with urine, a pair of glucose in urine, and such way increase to osmolarity of urine. It leads to increase of the osmotic pressure of urine, and we know that it leads to increase of the water releasing with urine, because increased concentration of different ions and increased concentration of glucose lead to uptake of the water from the bloodstream into the urine, and it lead to polyuria. Polyuria, of course, lead to dehydration of the organism. Polydipsia, and of course, it lead to polydipsia. They start to drink a lot. Loss of glucose with urine, of course, stimulate the eating of, and such way lead to polyphagia. What else happened? Without the blocking effect of insulin on the keto body production, without this, you see, in the absence of insulin, it lead to increased production of ketone bodies in the liver. Without the block effect of insulin, we will see the increasing of lipolysis, because we know that insulin activate lipogenesis. Without insulin, we will see activation of lipolysis. Without insulin, we will see decreasing of ketone body utilization in peripheral organs and tissue, and all of these reasons lead to increasing of concentration of ketone bodies in the blood, hyperketonemia. And ketone bodies, they are ketoacid, acetoacetate and beta hydroxybutyrate. They are ketoacid. That's why hyperketonemia lead to ketoacidosis. Enzyme hormone which is produced in the alpha cell, vice versa. This hormone, main function of this hormone is increasing of the glucose concentration in the blood. Glucagon is a single polypeptide chain of 29 amino acid residues, and like insulin is derived from the longer precursor, pre-proglucagon, and after that proglucagon, and only after that at last active glucagon by limited proteolytic cleavage. Even in the absence of significant physiological activity or stress, during the several hours after the intake of the dietary carbohydrates, blood glucose level falls to below normal because of the continuous oxidation of glucose by the brain and other tissue. Low glucose in the blood triggers secretion of glucagon and decreases insulin release. Glucagon causes an increase in the blood glucose concentration in two main ways. Like epinephrine, glucagon stimulates the net breakdown of liver glycogen by activating of glycogen phosphorylase and inactivating of glycogen synthase. Both effects are a result of phosphorylation of the regulated enzymes triggered by cyclic AMP. But about the mechanism of action of all hormones, we will tell with you later. But unlike epinephrine, glucagon inhibits glucose breakdown by glycolysis in the liver and stimulates glucose synthesis by gluconeogenesis. Both of these effects result from the lowering the level of fructose 2,6-biphosphate. Maybe you remember this regulatory molecule which is produced in the liver and has allosteric effect. Fructose 2,6-biphosphate is allosteric inhibitor of gluconeogenic regulatory enzyme fructose 1,6-biphosphatase and is an activator of phosphofructokinase. Glucagon also inhibits all three regulatory enzymes of glycolysis. Such way, by stimulating of liver glycogen breakdown, preventing glucose utilization in the liver by glycolysis, and promoting of gluconeogenesis, glucagon enables the liver to export glucose to the blood, restoring blood glucose to its normal level. Also, its primary target is liver. Glucagon, like epinephrine, also affects adipose tissue, activating triacylglycerol lipase by causing its cyclic AMP-dependent phosphorylation. This lipase liberates free fatty acids which are exported to the liver and other tissue as a fuel, thus sparing glucose for the brain. The net effect of glucagon is thereby to stimulate glucose synthesis and released by the liver and to cause the mobilization of fatty acid from adipose tissue to be used instead of glucose as a fuel for the tissue other than brain. I'm talking about insulin and glucagon today in brief because we had a separate lecture on the hormone regulation of carbohydrate metabolism where we discussed this in detail. But all this scheme you can see the same, the metabolic effect of glucagon on the main metabolism way in our body. And here you can see the target enzyme, main regulatory enzyme of each of these metabolic ways. Somatostatin. If you remember, we discussed today about one of somatostatin which is produced in the hypothalamus. And hypothalamic somatostatin took part in regulation of the growth hormone production in the pituitary. But somatostatin, it's also polypeptide hormone, and it can in this somatostatin can be produced in the pancreatic delta cells. Some of somatostatin, some part, can be produced in intestinal cell the same, not only hypothalamus. Somatostatin, which is produced in the pancreas delta cells in the pancreas, it has a paracrine mechanism of action, and the main function of this hormone is regulation of secretion of insulin and glucagon by the pancreas, corresponding in the beta and alpha cells. And the last hormone that we will discuss today is hormones that took part in regulation of calcium and phosphate metabolism in our body. You know that calcium is an essential intracellular signaling molecule and also plays a variety of extracellular function. That the control of the body calcium concentration is a very important. The components of the system that maintain the calcium homeostasis include cell types that sense changes in the extracellular calcium and release calcium regulating hormones, and the targets of these hormones including the kidneys, bones, and intestines. And these cells in the kidneys, bones, and intestine, they are respond with the changing in the calcium mobilization, excretion, or uptake. Two hormones, parathyroid hormones, and calcitonin, and one vitamin, vitamin D, they are primarily concerned with the regulation of the calcium level in our body, mainly in the blood, so they regulate calcium homeostasis. Parathyroid hormones is secreted in the parathyroid glands. It's understandable. Its main action, its main function is to mobilize calcium from bone and increases urinary phosphate secretion. Let's tell about what is the function, how this hormone acts. Human parathyroid hormone is a linear polypeptide that contains 84 amino acid residues. It is synthesized as a part of the larger molecule pre-pro-parathyroid hormones, traditionally. A hormone released by a parathyroid glands that acts to keep a constant level of calcium in body tissue. Humans usually have 4 parathyroid glands, 2 embedded in the superior poles of the thyroid and 2 in its inferior poles. The half-life of parathyroid hormones is approximately 10 minutes, you see, very short lifetime. What is the action of these hormones? Parathyroid hormone acts directly on bone to increase bone reabsorption and mobilize calcium ion. In addition to increasing of the plasma calcium ions, parathyroid hormones increases phosphate excretion in the urine and thereby depresses plasma phosphate level. This phosphatiuric action is due to a decrease in reabsorption of phosphate. Parathyroid hormone also increases reabsorption of calcium in the distal tubules in the kidney. And one more very important function of this hormone. Parathyroid hormones increases the formation of 1,25 dihydroxycholecalciferol. If you remember when we tell about the way of vitamin D activation, the second final step of its hydroxylation, which occurs in the kidney, an attachment of this OH group is regulated by the parathyroid hormones. And already this active vitamin D, 125 dihydroxycholecalciferol, it's already increase reabsorption of calcium in the kidney and increases calcium absorption from the intestine. A decrease in the secretion of the parathyroid hormones lead to a reduces resorption of calcium from the renal tubulus, decreases absorption of calcium in the gastrointestinal tract, and decreased reabsorption of calcium from bone. The serum calcium level falls. Name of this is hypocalcemia. It's increasing neuromuscular excitability and leading to muscle spasm, tetany, and death if the hormone is not replaced. What it causes of the abnormal production of the parathyroid hormone? The causes is usually unintentional damage to or removal of the parathyroid glands during the thyroidectomy. There is a rare, very rare, we can see idiopathic form in which the parathyroid hormone are absent or atrophied. What is symptoms of this abnormal situation? Maybe two variants. Hypoparathyroidism, low production of this hormone. It is often asymptomatic in the early stages, and the most characteristic sign in tetany with paresthesia of the lips, tongue, fingers, and feet. Maybe facial spasm, maybe muscle aches, and fatigue. Encephalopathy, depression, dementia, and papilledema may also be present. If we tell about high production of this hormone, or a very high activity of this hormone, hyperparathyroidism, it may be due to the abnormal production of parathyroid glands, one or all four parathyroid glands. It may be hypertrophies of them or any unknown reason of the increasing of secretion of parathyroid hormones. And of course, it leads to elevating serum calcium level. Increased calcium causes renal calculi and decrease of neuromuscular excitability and delay in the gastrointestinal motility, defects in the cardiac conduction, and decreased neuronal permeability. Calcitonin. Calcitonin is secreted in the thyroid glands. Human calcitonin contains 32 amino acid residues. As I tell already, secreted in the thyroid gland in the answer on the abnormal level of the calcium in the blood if the calcium level is higher than normal, because the main function of this hormone is decreasing of the level of calcium in the blood. Beta adrenergic agonists, dopamine and estrogens and gastrin also stimulates calcitonin secretion, not only high level of calcium in the blood. The action of calcitonin are short-lived because it has a half-life of less than 10 minutes in the humans. Receptors for calcitonin are found in the bones and kidneys. Calcitonin lowers circulating calcium and phosphate levels. It exerts its calcium lowering effect by inhibiting bone resorption. This action is direct, and calcitonin inhibits the activity of osteoclasts. It also increases calcium ion excretion in the urine. Unlike parathyroid hormones and active vitamin D, calcitonin does not appear to be involved in the phosphate homeostasis. No syndrome due to calcitonin deficiency has been described. More hormone is secreted in the young individuals. It may play an important role in the skeletal development. In addition, it may protect the bone in the mother from excess calcium loss during pregnancy. Bone formation in the infant and lactation are major drains on the calcium stores, and the plasma concentration of 1,25-dihydroxycalciferol are elevated in pregnancy. They would cause bone loss in the mothers if bone resorption were not simultaneously inhibited by an increase in the plasma calcitonin level. Unfortunately, the time of our lecture is over, so we will continue tell about biochemistry of hormones during our next lecture. Thank you for your attention. Goodbye.